Hi, everyone. Welcome to today's webinar. The topic for today is wound care management. My name is Liz Jensen, and I'll be your host for today's presentation. Thank you to everyone who's joining us today. As a reminder, this webinar is intended to provide general information, but not legal advice. We have a great expert joining us today, and I'm so honored to introduce her. Jeanine Maguire is the Vice President for Skin Health and Wound Integrity at Genesis Healthcare. Jeanine is a physical therapist and a certified wound specialist who has worked in many settings with a single focus on improving wound care for almost 3 decades. Today, she will share insights on how to implement a successful and evidence-based program. We're thrilled Jeanine is joining us here today to lead this webinar. Take it away, Jeanine.
Thank you, Liz. Thank you, everybody, for taking the time out today to hear this discussion about going beyond a Band-Aid and how to implement a universal wound model to create an evidence-based, patient-centered wound team. So let me just chat about this for a moment to kind of set the stage. The practice of wound care can be used to really understand how the medical-centric approach to care fails to connect the complexity of any human, and it really prevents us from achieving patient-centered outcomes. So this session today is going to go beyond that Band-Aid approach and discuss how this universal wound model can be put into practice to address internal and external factors from a systems thinking perspective. This will help to achieve patient-centered and an interprofessional team approach. I'm going to use some case study demonstrations to really demonstrate interdisciplinary contributions and ultimately hope to raise your awareness of how this interprofessional, how the roles, how the collaboration of the roles can achieve new levels of success. So let's start by talking about the why around wounds. Chronic wounds are a societal and an economic burden. We now know that there are more than 1.2 million pressure injuries. The expense exceeds 28 billion, and this is only increasing with population aging, increasing with chronic disease, and also increasing with frailty. And we now know that there's been a relationship between frailty and chronic wounds. In fact, Franz et al. In 2020 did a cross-section analysis and found that 23% of those that had frailty also had some type of chronic wound. The background on chronic wounds, what most people don't understand because they see a wound as perhaps a fault or an issue with the care that was provided or the center that they reside in. But many chronic wounds are actually the long-term result of the social determinants of health that lead to the different chronic diseases that indeed lead to wounds. Now, when we look at social determinants, we look at chronic disease and aging, it's important to know that in the United States, those that are older than 65 years of age is estimated to double by 2050. That estimates a 100% increase in the Medicare spend, and that's from the CDC in 2016. That accounts for the chronic diseases, the most common heart disease, stroke, cancer, and diabetes, all also major causes of chronic wounds. What's important for all of us as caregivers, particularly those of us in post-acute care, is this disproportionately affects those who reside in nursing homes and also has a significant impact on the nursing home itself. Some of the impact on the patient, the resident, the family, the staff, and the nursing home. When we think about that individual who actually has that wound, for them, that wound could have drainage, it might have odor, it could cause embarrassment for them to maybe leave their room or to have company or to go to an activity. It certainly can impair their quality of life. It can cause infection, hospitalization, require surgeries, antibiotics, and in some cases, even be the reason behind sepsis and death. For our caregivers in the field, particularly the nurses and the CNAs and anybody else engaged with that individual's care, It can cause a lot of worry and frustration, fatigue. There's a lot of difficulty in caring for people with multiple chronic wounds. Also, fear that perhaps they're not doing the right thing or they might get in trouble because the perception is they haven't done a good job. It leads to poor job satisfaction for those individuals who are really there to make a difference for those individuals and ultimately can affect their quality of life. For the establishment of the post-acute care setting, whether we're talking nursing home or other, anytime there's wounds, it can result in some expensive fines, regulatory tags. It certainly can harm the reputation within the community. It can result in decreased reimbursement, decreased referrals, as well as litigation. I want to talk about systems thinking a little bit in this slide. The one thing we know from Demings is that all systems are created for the exact results that they get. And what this slide is attempting to depict here is when you have a healthy human in a healthy facility that's running well with a good process, wounds are not going to be an issue. And even when those individuals are admitted with chronic wounds, the person who's medically managed, they have more mobility and so forth, they are a healthier individual that's managed within a healthy facility. You're going to be able to manage that person's skin health and wounds. However, if that healthy individual is in an unhealthy setting and they don't have clear processes and policy and framework and teamwork, they're going to be at high risk for developing other wound issues or high risk of having the wounds that they were admitted with decline. If you have an unhealthy individual in a healthy setting, we've got a shot at helping to improve that individual, but we have to look at that person holistically. And when you have unhealthy individuals in unhealthy settings, that's the recipe for disaster. So some ground rules before we jump into this idea of skin health and a universal model. 4 rules. Number 1, a wound is a physical manifestation that occurs when the body and the mind are not in harmony. So when you're not in the state of homeostasis. A wound outbreak in a center is a physical manifestation that occurs when that center, that facility, is not in harmony or homeostasis or health. Also remember that regardless of the conversation around social determinants, even that individual who is very unhealthy and has chronic disease, most pressure injuries, so that one particular type of chronic wound, most pressure injuries are preventable most of the time. Not all of the time, but most of the time. However, once that individual has that pressure injury or other type of chronic wound, healing a wound is actually not always possible when we're really practicing in that paradigm of patient-centered care, where they're driving the bus and making the decisions based on knowledge of benefits and risk of what's available to them. However, even if healing the wound is not the ultimate goal, always striving to work together to heal the person who has a wound is possible. So let's kind of dive in now and talk about the difference between what we really do today in most settings, which is a more medical centric, or what I refer to as just a Band-Aid approach. It doesn't actually go to root cause, address root cause, or do good for prevention going forward, versus that patient-centered approach. So let's kind of talk about the differences between these two. We do know that the med-centric approach is a focus on the wound, not on the human who has a wound. The effort here is to find the best topical Band-Aid, the best topical treatment. However, we have very low wound literacy. So we all know what health literacy is, but wound literacy is actually understanding root cause analysis of different wound types, understanding and recognizing different wound types, understanding the pathways that are possible for healing or management or palliative for different wound types, understanding that of the 5,000 or more treatments on the market, many of them are based on savvy advertising. Many of us don't have the ability to really look at the research to identify the treatments that are based on evidence. And often the care is clinical centered care, meaning the goals are set by us as clinicians and not really diving deep to find out what's the patient, the resident really willing to do? What do they really understand? And if they understood what it took to get to healing, would healing really be the goal? The impact of this med-centric approach is survey deficiency. It does not appear that we're doing a whole lot better in this area. Same with litigation. Errors on MDS, if you're in long-term care, that could impact your reimbursement or PDPM. And also the quality measures that specifically look at pressure injuries. And I always wonder, are they actually really pressure injuries? The med-centric approach, again, offers a very limited and fragmented look at chronic wounds. And that's not just one particular discipline, that's all disciplines. So, from providers, physicians, nurse practitioners, the nursing team, therapy, and dietitian, we're all working in a silo with a very small knowledge of wound care, often, not always, within our own discipline. And often we don't even understand what the other discipline's role is or how to even integrate, which leads to the ineffective communication across the team. It also leads to a really difficult obstacle of getting that team to integrate. It contributes, obviously, to poor patient outcomes, poor patient and family and staff satisfaction. These are not my observation. This is based on the evidence that's available today around this med-centric approach. So, if you think for a moment about an individual who has developed a wound, the one question I always have is, why today? Particularly if that person's not a new admission. I mean, a new admission is pretty obvious, right? If somebody's admitted to a nursing home, they probably had a significant acute event that landed them in acute care in the first place. Their body's not healthy. They're not in a state of homeostasis. They probably have new medications. There's probably a lot of psychosocial issues occurring at that moment. Their life is just blown up. Now they're in a nursing home, even if it's for rehab, it's still a significant change in their life. They have a roommate that they don't know, that perhaps they have cognitive issues themselves or their roommate. So their whole world is upside down. So it makes sense that most of the in-house acquired pressure injuries do occur within those first few weeks of admission because the human is not in a state of homeostasis. So the ownership is on us to really intervene, evaluate, look at that skin, make sure the interventions match every single risk factor. However, what always perplexes me is when somebody develops an in-house acquired after they've been living in a facility for a while. They've been with us for at least a month or longer, or a year or two, and they develop a new wound. And then my question always is why today? Why now? What has changed about this individual? And is the wound the result of a change in condition that they're experiencing? Or is it your clue? Is it the beginning of a changing condition? Because something has changed. Something has changed. And this is part of the shift that I want to suggest to you around the paradigm of how to look at skin a little bit differently. So I want to reiterate again that when it comes to chronic wounds, they are absolutely increasing in long-term care with population aging and the result of chronic disease. And we know that the current strategies that we're using today with that med-centric approach, they're not meeting our needs, they're not meeting our resident needs, and they are absolutely resulting in negative outcomes. We know that we need an evidence-based approach, and the evidence is clear. We need to look at the concept of skin health as a marker of overall human health. We need to integrate our care with teamwork within that lens of what's most important to that individual, in that lens of patient-centered care. Again, This is just not my own opinion here. This is based on the evidence of other patient-centered team approach strategies that have resulted in success with outcomes, quality of life, and team satisfaction, employee satisfaction, which we all need to improve our retention, right? So, based on the evidence, we've seen these great outcomes for palliative care, dementia, diabetes, limb salvage, and so forth. So, when we're thinking about the overall skin health and what skin can tell us, let's say this individual is at risk, which most are, or they have an actual wound. When that person has an actual wound, for example, if you ask me to lead the team in consultation, I don't even want to see the wound until I first addressed all of these other factors. And then we can take a look at the wound and sort of work backwards again. So we want to look at vital signs. Have they had weight loss? Do they have nutritional risk? Is the nutritional risk because they're not eating, or the weight loss because they're not eating? Are they not eating because of altered sensation of taste, medication, COVID, missing teeth, dentures, cavity, pain, swallowing, difficulty holding the utensils, food preference? Do they have issues with oxygen perfusion? Because if they're having issues with oxygen perfusion, they have an active COVID infection, they have COPD, their pulse ox is very low. Our bodies will logically shunt oxygen to the organs that sustain life, which will be your heart and lungs, and not so much your skin or that wound for healing. So do they have issues with oxygen perfusion? I need to see some labs. I need to see what the hemoglobin's looking like. Do they have issues with their blood sugar? Do they have diabetes? What's the A1C? Do they have other chronic diseases that are not managed that could be impacting skin health? Do they have issues with inflammation, active infection elsewhere in the body, moisture impairment, whether it's skin folds, whether it's urinary incontinence, impaired mobility? Do they have medications that will impact healability, like long-term steroid use, like anticoagulants, medications that could impact sensation, depression? Do they have sensory or cognitive impairments, contractures? Is their environment conducive to good skin health? What's the bed surface like, the seating surface like? How can they properly move in their room? What do we do to encourage that mobility? So clearly, when we have these discussions, this is none of this information is going to be owned by one particular professional or discipline. Collectively, we can do this, but this is truly that team approach between that provider, the resident, their family, the nurse, the therapist, the dietitian, and others. Collectively, we can truly address all of these risk factors to make sure that we're looking at the patient holistically. So that's sort of the essence of what that team does. Now, the universal wound model has a couple different attributes here. So there's 5 components. The first is you need a key leader. The second, you need a referral mechanism, which means that you need to understand what everybody's roles are and who you have available to you. Very basically, I mentioned, poor denture fit. It could be that that dentist is part of the team. So how do we know when and who to reach out to? We certainly know that for the admission to long-term care, we want to make sure that nurse knows their role in doing a full body skin check upon that admission. We also need team cohesion, and part of team cohesion is having emotionally intelligent conversations. But in order to do that, we need to understand what our role is and what your role is. We also have to understand that there's an emotional impact around open wounds because there's a lot of fear, finger pointing, and low wound literacy. So that leads to a high need for sensitivity in our conversations with each other. You want alignment of reimbursement of the structure. So what that makes me think about in long-term care is What are our metrics? So most long-term care facilities or organizations have their own internal metrics to incentivize or to kind of keep tabs on how facilities are doing before it ends up on the MDS or a quality measure. So the question here, does the metric structure support transparency, reporting? Does it support teamwork, or does it cause more finger pointing? In addition to that, do the team members understand what is indeed reimbursable versus what's not, and how to provide care within a structure to get the best financially responsible outcomes? And then lastly is the readiness. Now, readiness is a lot of different things. Number one, it's making sure people have education. It's making sure team members understand each other's roles. It's expectation of the way we communicate with each other with compassion. It's having policy. It's having guidelines, coaching, and a shared mission and vision for how to do collectively interprofessional patient-centered teaming. So one thing that you can do is create a position of a dedicated leader. A lot of people say, oh, we have a treatment nurse or a wound nurse. And often that is somebody that does treatments, which is a great thing. But that's not somebody that oversees an entire program from prevention to management, understands and teaches every discipline's role in wound management, leads process improvement efforts, does audits, makes sure the care planning is correct, does your risk management evaluations, investigations, and so forth. So this is somebody who probably should be wound certified, but really has the ability to oversee the entire program. And it needs to be a specific job code and a specific position. There also needs to be coaching, so this individual truly understands what their role is. In terms of readiness, it's also important, as I said, that you have policy and framework to support this. This is the environment. This is the systems thinking. Too often I see in facilities where, somebody is just selected, voluntold to be the wound nurse or the team leader. It has to be within a structure. And so you want to have training videos, you want to have coaching and a whole education program or residency. You want to have team training for the team, even videos of how teams should engage with each other. Leadership training, so the center leaders understand the role of this individual, so they support it. You want to have tools and resources at their fingertips so they know what to do every day on a daily basis. And also the ability for them to network with each other across other facilities with community calls. You also want to make sure that that team lead is, again, that designated position with a job description, and it's a paid position. I can tell you in history, this job, again, was always somebody that was voluntold that they are the leader of the wound team. And during crises, when there's an outbreak, this was often the first role that was pulled then to do other things. When that happens, your basics will be lost. The team will fall apart without that coach leading them. So it's so important that this is a designated individual. And then again, they bridge that team and support everybody else in that facility. So when you look at this, it's the provider, it's the CNAs, it's central supply, it's the administrator, the director of nursing, the primary physician, the educators, all nursing staff, including agency, who are part of that team. So we have to figure out how to pull them in. It's your MDS coordinator, your Part B coordinator for wound supplies, the resident, the family, the therapist, the dietitian, the dentist. So it's that individual that can pull this team together and really make sure that team members understand each other's role as well in really looking at mobility and function, making sure that we have alignment. Looking at the nutrition, the swallowing, the weight loss, the vital signs, the labs, the chronic condition, the medication, and really working with social service, family, and others on what matters most for that individual. And then, as I said, think about your metrics and what drives change. So what I mean by that is you may not realize this, or perhaps you do, but a stage 1 or stage 2, those are superficial, partial thickness wounds. They're epidermis, maybe into the dermis. Okay. We're talking millimeters in depth here. When it's a stage 1 or 2, these can happen in 1 or 2 hours in some cases. If something can happen in 1 or 2 hours and your CNA finds it, because the CNAs look at skin every single day, they report it, the nurse responds, checks, and says, you're right. You just found this stage 1 or 2. This is not a bad thing. If a stage 1 or 2 could happen in 1 or 2 hours, and we know it occurred because likely that person is experiencing a change in condition, that CNA just did a wonderful thing by recognizing it, having the education to know what to look for, following a process, a structure in the center that they reported it, and the nurse responded. This is a good thing. So think about that. When you think about metrics, if people can find pressure injuries at a stage 1 or 2, it means early identification. But even more, stage 1 and stage 2, even on people that are very vulnerable and very unhealthy, oftentimes a stage 1 or 2 can still heal with basic Band-Aid approach. Obviously, you still dive in deeper, find out the why, the root cause analysis, make sure the wound type is accurate. What interventions can we do to help with healing and to mitigate further breakdown? Absolutely. But the point is stage 1 or 2 means your process is working, your people know what to look for, and your nurses responded. And even more importantly, that person's probably going to heal. And they're probably going to heal in just a couple weeks at the most. However, when it comes to anything more than that, stage 3, stage 4, and even unstageable and DTI, this is where things get much more difficult. Generally, unless that person is actively dying, generally a stage 3 or 4 or unstageable, that's not happening in a few hours. So you really want to find out who saw their day, yesterday, the day before. Interview those individuals. Did they see this occurring? Did they know what it was? Did they report it? Were they responded to? So it might be that you have an education issue in your center for your CNAs. It might be that you have a policy, a framework, a process issue, a system issue. What do they do? When do they report? How do they report it? It could be that it's a nurse issue. So did the nurse respond? Did the nurse respond timely? So you want to do a root cause and find out, what's occurring in the center. And then obviously do a root cause and find out, why is this individual breaking down in the first place? But the thing with the stage 3, 4, unstageable and DTI is that these are they're always stage 3, 4, and unstageable. They are always a full thickness, meaning you don't have skin in the game. Your epidermis, your dermis, they're gone. And so now to get to healing, not only do you have to make sure that the other chronic conditions are being properly managed, but we have to look at that person again holistically. What's their blood sugar? What's their hemoglobin? What's their oxygen perfusion? What's their mobility level? What's the cause of the breakdown? Can we mitigate those causes? How long might it take to get to healing is different for every single individual and depends on the depth of this wound and other issues that occurred. But at a minimum, from what I'm seeing out there with a stage 3 and 4 or an unstageable in an older person that is not healthy, this becomes very difficult to get to healing, especially in a couple months. I mean, this is going to take a really long time. And the patient has to understand what it's going to take on their part too, in terms of nutrition, offloading, specialty devices, specialty beds, specialty cushions, and so forth. Are they willing to play? Are they willing to go down that path to get to healing? And what is their anticipated lifespan? So when you're thinking about metrics, what you want as a never event would be an avoidable stage 3, 4 unstageable. Now, the DTI is a little bit more difficult, so you definitely need to investigate the why behind that, make sure it is indeed a pressure. And sometimes they certainly do evolve, and that's the natural evolution to a full thickness, and sometimes they don't. The Kennedy's terminal ulcer is a little bit more difficult. There's a lot of subjectivity in evaluating for that, but there are certainly things that we can look for. So we have to evaluate that person's, again, holistically, their overall state of health or lack thereof, and try to determine, is this really skin changes that are happening at life's end and would have occurred regardless? So the primary cause is not actually pressure. And then we have to figure out two really important things, okay? Even if it is skin change at life's end, even if it is some type of Kennedy's terminal ulcer, and we feel really confident in that as a team based on the overall picture, you still got to prove that it was regulatory unavoidable. So even if that provider writes it's medically unavoidable, you can still get a survey tag, because you also need to know the federal regulations, which basically, even if it is a Kennedy's terminal ulcer, did we evaluate the risk before the breakdown happened? So if that individual is having some significant change, did we say, wait, let's reevaluate the risk for skin? Did they have interventions that were patient-centered and evidence-based? And were they being done before the breakdown happened? When the breakdown happened, did we catch it as early as possible? And did we reevaluate and revise those interventions? So if we did those things, and we can document that, or we have the documentation that we did those things, then you can feel confident that you met the critical element pathway, and it is also regulatory unavoidable. I don't think one clinician can do this. This is really a team approach and a team investigation. And then I just want to throw out one other question, because when I go to different facilities, what I often find is it wasn't even pressure to begin with anyway. We should never even called it pressure. We should have never staged it. It had a completely different etiology. So working with the team to investigate and make sure that you know the wound type and the wound type is accurate, reaching out to a certified wound specialist when needed to make sure that that wound type is accurate is also key. All right, so here's your warning. We have some wound pictures coming up. Okay, so this one is indeed a pressure injury. And so when you're looking at that pressure injury, you can see that out here you have areas of darker skin. You have some erythema, some darker purpley areas in here as well. Within the actual wounded area, you have some slough necrosis. You also have a lot of very moist eschar covering a majority of this wound. There are some openings that we would certainly want to gently probe with a sterile moist swab to see if we can touch down to any muscle, bone, or tendon. But when you're looking at this particular wound, can you guys let me know what stage you would stage this as? So I'll give you just a moment to go ahead and respond.
Yep, I've got the answer to the first poll here.
Yeah.
People have selected unstageable as the answer.
Yeah, that's great. That's absolutely correct. So unstageable means that a pressure injury has so much necrotic tissue, whether it's slough or eschar, that you are unable to determine how deep it really is. You're unable to determine whether it is a 3 or a 4. Rest assured, it's a 3 or 4. We just don't know which. So you're going to term it as unstageable. Now, this one I would also say is unstable eschar, because it's moist. You have these pockets here. You have this erythema. This is very concerning. So this is somebody who requires some debridement very quickly. We need to kind of uncap this and find out how deep this really is. I'm very worried about bioburden and the potential for local and likely even systemic infection at this point. So this is a full thickness. And when we look at this individual, in addition to managing bioburden and debridement, we have to look at mobility, incontinence, the turning schedule, the specialty surface for the bed, the chair. You know, this is high up on the sacrum, so this is more likely probably from the bed than the chair. So we want to make sure that person is offloaded. We need wedges. We need a glide sheet so we're not causing drag and shear and undermining for this individual's wound. We need to look at chronic conditions, oxygen perfusion, and so forth. So again, we really want that team approach. And I don't even think I said the dietitian. So we need to look at nutrition as well, because if that person is losing weight, they're not going to heal. You cannot be losing tissue and gaining tissue at the same time. Even if this individual weighed 500 pounds and you might think, oh, weight loss is desirable, you cannot lose tissue while building tissue at the same time. So we really need to look at all different aspects. All right, let's do another one. Okay, so this is intact skin, but you can see some areas that are hyperpigmented. And when I press down on them, they are not blanching. So this is a pressure injury. What stage do you think this one might be?
We've got our poll results in here. 89% say stage 1.
Easy breezy, right? Really smart group. Thank you for that, guys. So this is indeed a stage 1. Stage 1 is not open. It's discolored, but it's not maroon. It's not deep purple. That would indicate a deeper tissue injury. This is that stage 1 that if you found a stage 1, couple things, guys. Number 1, stage 1 is an evolution. You don't live in the state of a stage 1. So if this person's skin still look like this in a year, it's them. Not a stage 1, okay? So a stage 1 is the beginning. It's that hyperemic response. Again, it's not blanching. And so this is either going to get better because we recognized it, we offloaded it, we got them on the right surfaces, we got mobility going, we got the dietitian involved, we looked at comorbid conditions and so forth. So it's going to be gone likely in a week or so, or it's going to start to decline. So you're not going to live in that state of a stage 1. But if somebody finds this, you want to celebrate. You want to acknowledge that CNA found this early on, because this person could have been the one that prevented what we just saw on that other slide. Because if you can catch it here, you're not going to have problems like that unstageable pressure injury. Great job. Okay, so this one's a little tricky. This is also, all right. So I'm not going to ask you for a stage here because I don't know if this is a pressure injury. Now this is indeed on the back of the heel. So it's on the back of the heel. If you were laying down right now, listening to this, your heel would be resting. This part of the heel would be resting on your bed. Okay. So if you're standing up, you're not standing on this wound. It's behind your heel. This person does have arterial insufficiency. They also have diabetes and neuropathy. They also have venous insufficiency, which is the number 1. Venous leg ulcers are the number 1 leg ulcer in this country. So given that little bit of background, this individual also is relatively immobile and requires assistance to get in and out of bed. Not full assistance, but some assistance. So given that very little brief description, which wound type is most probable without diving deeper? What are you thinking first?
The majority says it's a pressure injury.
That's correct. The majority are correct. I see the other answers all the time, though. Just because somebody has diabetes does not mean any wound on their leg or elsewhere is a diabetic wound. So a diabetic neuropathic wound occurs on a walking surface from acute repetitive injury on that neuropathic limb. The back of the heel is unlikely to be a walking surface. Just because somebody has arterial insufficiency does not render any lower extremity wound a lower extremity arterial wound. Okay? Just because they have venous insufficiency does not render any wound a venous ulcer. So the clues that I gave you, location, location, location. If somebody says so-and-so has a pressure injury, you want to say why? Why do you think that? Did you examine that person, observe that person with your eyes, with them in their environment, in their bed, in their chair, in their shoes, their devices, and the way in which they position? Do they position on the wounded area? Do they have mobility impairment or neuropathy? I've seen pressure injuries on people who don't have mobility impairment but can't feel it all. So, for example, similar to this, I had an individual who would rest their foot on the wood post of the bed for hours on end. They could move. They just didn't feel the need to do so. So that was still a pressure injury. The neuropathy was the risk factor that we should have evaluated for to mitigate. So the other factors like the neuropathy, the diabetes, the arterial insufficiency, the venous insufficiency, those are risk factors that increase the risk of wounding and could prevent healing or delay healing at best. So we'll still need to address those factors, but they don't become the wound type. All right, fantastic. Let's try to squeeze another one in quick here.
Okay.
So when you're looking at this skin and this wound that's slightly open, so it's slightly open, okay, we have the epidermis is gone. It is very superficial, and it is indeed a stage 2. So the pinker area in the center that's kind of raw and slightly open, how would you describe that tissue in the nursing home setting for the MDS?
Our answer is open epithelial.
Wow. I'm so impressed. Correct. That is the right answer. So a lot of people, thanks to MDS 2.0 years ago, made us call everything pink or red granulation. We still do that. That's not correct. So granulation only occurs in a stage 3 or 4 deeper wounds. It's brand new blood vessel growth and so forth to fill in that hole. You don't need that here. This is just dermal cells that are healing. Recreating themselves in the superficial wound. So indeed, it is open epithelial tissue, and that's the way it is actually on the MDS, and your reference for that is the REI manual. Awesome, because if you say it's a granulation, then it looks like you don't know how to stage, or you're saying it's a 2 and it's an actual 3 or something like that. So you want to be careful with that.
All right. And I'll just add, Jeanine, too, because we saw this came through the poll as well, that granulation actually was a close second. And so that is an important distinction then.
Yeah.
And I think
thank you for that. And so take a look at this one. So this base, this is granulation. You can see here that the epidermis and dermis are gone, because remember, epidermis, dermis, millimeters thick. So this one does have, you can see a wound edge, there's depth. The base is truly granulation tissue. And you might be thinking, geez, I mean, this wound is so small. It's deep though. Epidermis and dermis are thin. So this is 100% granulated. And for sake of time, I'll just tell you, this is a stage 3, 100% granulated stage 3 pressure injury. All right. Now, I just want to show you this one because sometimes we call everything pressure. And our federal guideline says that if something has some characteristics of a pressure injury, but is not a pressure injury, don't call it pressure, but you need to explain the rationale in your documentation. So you want to think about that. You know, this is on the gator part of the leg, kind of the shin area. And what we needed to do was observe this person supine, sideline, sitting with their devices on, learn the history, look at comorbid conditions, mobility, and so forth. And basically, this area was void of pressure. This person was indeed immobile, but the areas that they positioned on, their heels and their sacrum, were beautiful and intact. No pressure injuries whatsoever. So you want to document your observations and your findings and why you believe this wound type is not a pressure injury and likely some other type. So this was not a pressure injury. So what drives change when you're thinking about metrics? So what I want to suggest to you is that you're trying to get a metric of 0 in-house acquired, stage 3, 4 unstageable, right? That would encourage that teamwork to find and report the stage 1s and 2s early. Celebrate that. Make sure there are even pressure injuries and have a process that if it is truly unavoidable, regulatory and or medically, that you have a team review of a wound specialist, perhaps outside your center, that reviews that so the center is not penalized, but instead they're given the information they need to communicate compassionately with that resident and their family. In terms of communication, so Team Steps is a great resource, and you can modify one of their team performance observation tools. So I modified it for wound teaming, and this looks for certain behaviors in communication with each other. So you can use this to actually, do a little test of your teaming and see how your team does in terms of communication. And then it gives you a score so you can try to work toward it. So that's an area that we often don't look at in metrics, but this could certainly be one of the metrics. How is your teaming communication? You want to do a center assessment and set some goals. So you want to look at process improvement for wound management that goes beyond just making sure that the CNAs are turning people. Important, yes, but that's just one piece of it. A great example is if your bed surfaces are all outdated and dead. If your mattresses are 100 years old, which I'm sure none of them are 100 years old, but if those mattresses are even more than 4 to 7 years old, there's a good chance some of them might be completely non-viable. And I know this sounds a little bit corny, but guys, you can't outturn a dead bed. And so even if your CNAs are phenomenal, if your bed does not provide, any pressure redistribution, you're going to have breakdowns. So that's the systems looking beyond just the individual, right? You want to have checklist guidelines for your staff and for your team, what they do for skin, on admit for the first 30 days, how they work together, what happens when there's a new wound, and so forth. You also want to have guidelines, and I suggest you work with your vendor on this. So whomever your vendor is for your formulary, you need to have guidelines so your staff and the team know, what do we pick for the bed and chair? What are the options we can offer to our resident? What are the turning schedules that are appropriate? Because we know the 2-hour rule is debunked, right? It needs to be a variety based specifically on the individual's needs. We need to have a guideline for good skin care, making sure we look at skin every day, that a team member looks at skin every day, that we're using proper moisturizers and creams when appropriate to keep that skin healthy. We need wound guidelines and guidelines to manage bioburden. So we're not going to have time to go into this individual too much. I'm just going to share a story very quickly. This was an older woman. I believe she was in her 90s. She had every comorbid condition under the sun. However, she was able to make her own decisions, and she was very angry when I did see her. She often refused therapy. She refused her wound care. It says here she refused to get out of bed. What that should say, she refused turning and repositioning. She actually refused to go back to bed for rest breaks because she really enjoyed being out of her room and going to activities. Also very reluctant to make changes with her diet. The only foods that she liked were her chocolate cake. And this little lady had a very, very large wound, and the family was very upset with the center. The center was very upset because they couldn't get this individual to comply. They wanted me to come in and talk to her to get her to comply with the plan of care. And, with this individual's wound, she had bone exposure, she had rolled edges, the epibole, she had significant depth, she had issues with bioburden for sure. Her A1C was not good. Her mobility was very poor. Even when she was out of bed, she did not want to, again, get rest breaks or offloading in that wound, and so forth. And so in talking with her and talking with this individual, she understood she had a wound. She understood the risk of having that wound. She was agreeable to some of the treatments, but she was not agreeable to aggressive measures. She didn't want bone debridement. She didn't want to have, periods where she was off that wound every hour throughout the day. She didn't want to not eat her chocolate cake, understanding that that was going to interfere with her wound healing. And the reality, I think she was 96 at the time, even if we went full force ahead with an aggressive intervention to get her to healing, would she actually heal in this lifetime? And would that really impair her final time, her quality of life? And so it took a lot of team discussion and really thinking about all these different aspects. And it's not just one conversation, but collectively to come together with a plan of care that she was satisfied with around maintenance and comfort. But healing ultimately, although very much her family goal, because it was very upsetting for them to see this wound, was really not the realistic goal for her, because it's not what she wanted. She wanted her cake. So again, you want to really think about, how do we adopt this patient-centered team for the betterment of our residents and our centers and our staff? You want it to be evidence-based. And this is, by the way, it's expected in our regs. I mean, they talk about the team approach all over FTAG 686. We have all the right players. This is totally possible in post-acute care. What we have to do, though, is rethink our current structures, our culture, and really think about our communication systems within our center. How does that CNA say to the provider, I have something to report to you about skin? How does that provider acknowledge that CNA? So how do we change those hierarchical structures to improve communication, leveled communication across disciplines? We also know that adopting this will decrease your pressure injury rates. It will improve recognition, and it will give you a response rate to unavoidable pressure injuries that will remove the penalty and improve the communication around that. You'll have improved documentation and improved teamwork. Adopting this can also improve your PDPM rate, your QM for pressure injury, survey, and staff satisfaction. The halo effect of really managing skin and wound from a skin health perspective is it improves the overall health, not just of that individual, but truly that health of the center, the H and the H. And I just want to wrap it up by just sharing with you, I had a center that was very challenged for many, many years until we adopted this particular structure, and they gave me the permission to use some of these slides, but they created such a fun team approach that engaged all team members. And this is actually their night shift, and KNIGHT, where they were all creating a way in which they could really be the champions for skin. And I will leave it there and just respond to any questions you might have.
We do have a few that are coming through here, so we'll get right to it here. So the first question, Jeanine, is, I see you are a physical therapist. What are your thoughts toward the use of full body immersion hydrotherapy? For example, a Hubbard tank with properly chlorinated water for treating, quote, classic bed sores, unquote, lower extremity skin integrity compromise.
I would guide you to the American Physical Therapy Association. A couple of years ago, they came out with 5 things that we should not be doing anymore in treatment. And one of them is Whirlpool treatments for wounds. So I think Whirlpool, hydro, even full body may be very good for musculoskeletal injury in which the skin is not open. I don't know that we should be doing it for actual open wounds. Now, I'm not speaking about burns, but I am speaking about other chronic wounds, pressure injuries, and so forth. So my thoughts are I would not recommend it. Thank you for that. Good question.
Yeah, thank you. All right, the next one is, I understand the concern for cross-contamination, but do you see a balance between that concern and the added benefit of body core circulatory stimulation and more complete cleansing provided for a warm hydrotherapy environment?
I'd have to read any research if you're speaking of something new that I'm not familiar with. So I can't really respond to that except to say.
Yeah, it looks like, I'm sorry, Jeanine, it looks like that question was from the same person that asked the previous question. So it sounds like it was maybe an extension on that question.
Sure, yeah.
Okay, let's go to the next one then. Your thoughts on topical low heat in warm 96 to 98 degree Fahrenheit, 35 to 36 Celsius, combined with low intensity mechanical vibration as a circulatory facilitator to promote wound healing.
Again, I'd have to see the exact research that you're referring to or the product that you're referring to. Certainly, we know that vibration, and I'm thinking about things, say, like ultrasound mist, is actually very beneficial to wound healing. We also know that keeping the wound bed at a good temperature is good for wound healing. So with those 2 theories in mind, possibly it's good. But again, I need to read the research you're referring to or the product that you're referring to.
Got it. Good. Okay, good. Great. The questions keep coming in here. So the next question is, are there better dressings than others for stage 2 pressure areas?
Certainly there may be. There are hundreds or thousands of dressings or treatments on the market. But I will tell you that healable people will heal with an expensive or a cheaper dressing, especially with the stage 2, if you're keeping the wound covered, keeping it, the moist environment, making sure you're cleaning it properly between dressing changes, and then making sure you're offloading the source of pressure. You're looking at nutrition, you're looking at chronic conditions. The treatment itself is less meaningful than all those other aspects. So I won't promote any particular treatment. But if you're doing all those other things right, and you have a treatment that can keep the wound covered longer to maintain that cellular temperature, then that would probably be your best option.
Great. Awesome. All right, good. We have time for one more question, I think. Let's see, answer this one because this is an important one, I think, to be clear on. What are your thoughts on betadine use on the wound bed?
Okay, so betadine is cytotoxic. And so if you're trying to heal a wound, you should probably not destroy the healing tissues. If the wound itself is healable, and let's say, it's in proliferative phase of healing, or even if it's in inflammation, but you have good processes occurring within the human body, then I would not do that. I think if you have a closed wound that's covered in eschar and you want to keep that eschar dry and free of any external surface bacteria, then it might be appropriate to put it on the eschar and in between the edge between the eschar and the skin, but don't go crazy and paint all the skin, because then you won't see anything like erythema suggesting instability of that eschar. So it may have a very limited place, but I do not do it in open wounds. Now, that being said, there are advanced products, cadexamer iodine, where there's much lower cytotoxicity. You do still have some risk factors that you'd have to read the package insert to be aware of. But if you have a wound that indeed has issues with bioburden and perhaps also has some slough, there is definitely an appropriate place for those type of products.
All right, great. Wow, Jeanine, thank you so much. Thank you to everyone for all your questions. This concludes today's webinar. Thank you all so much for joining us, and we'll see you next time.